Good afternoon, everyone. I'm Fatima Park from South Africa, and my co-chair this afternoon is Patrick Beruski from the United States. A very warm welcome to this wrap-up session of what's been a very exciting and inspiring Congress. This afternoon, we're really going to be addressing quite a number of practical issues that we grapple with in the critical care setting. And it's a pleasure indeed to invite Jalali Anand up to the podium, who is extremely well known for his publications in the sepsis domain, who holds multiple professorships across France, and who certainly doesn't need much of an introduction. The floor is yours.
It's really a great pleasure being here with you, and I'm thankful really to Abdurrahman and his team, and really I enjoyed the 3 days that I shared with you. All good things have an end, so for my last talk, I will share with you some information about adrenal insufficiency in the ICU, whether it is a myth or a reality. So my second slide was about my declaration of interest, to say that you may consider a number of my activities within, so here my declaration of interest. In these different activities, of course, may bias the selection and interpretation of data I'm presenting to you this afternoon. I hope I can, yeah. So let's start with some physiological aspects. So here you can see on your left-hand side that the cortisol and all the steroid hormone released in resting condition are mainly related to the synthesis of corticotropin-releasing hormone by the hypothalamus that triggers the release of ACTH by the pituitary gland. That ACTH goes to the blood, reach the adrenal cortex, and then trigger the synthesis of cortisol. And that is also the case in physiological stress. However, in pathological stress, like trauma, infection, surgery, emotion, there are other activators of the HPA axis at the level of a hypothalamus, as well directly at the level of the adrenal cortex. So it is well known that the pathogen-associated molecular pattern or the damage-associated molecular pattern that are released during pathological stress will stimulate the release of cortisol by the adrenal cortex through complex mechanisms that in part involve the toll-like receptor. So, and this is known for a long time. As one can see in these experiments, one can see that as, the injection of insulin to the body resulting in hypoglycemia is indeed stimulating the release of ACTH and cortisol. But now if you challenge, not with insulin, with what's called a pyrogen, so something that will increase the core temperature, one can see that the release of corticosteroid is even higher than the stimulation by the insulin-induced hypoglycemia. And also known for a while that among the different stimulators that are relevant for sepsis is circulating levels of interleukin-6. And indeed, one can see that in looking at the levels, I'm looking behind me because I have nothing on my screen in front of me, so don't ask yourself why I am always getting back. So basically, one can see here that as compared to wild-type animals, when you challenge them with interleukin-6, you get an increase in ACTH level. And if you have animals, mice, that actually do not produce corticotropion-releasing hormone because you have made them deficient to produce this hormone, one can see that interleukin-6 still increase the level of ACTH and corticosterone, highly demonstrating that the mechanism by which interleukin-6 and other cytokines increase the levels of these hormones is not dependent of CRH-ACTH axis. It's okay, don't worry, it's okay. So, I thought it was okay, but now nothing, yeah, yes, now it's completely blocked. Okay, yeah, thank you. So, and again, one can see again here for corticosterone level that when you knocked out the mice, they cannot secrete corticotropion-releasing hormone. Obviously, they are not able to produce corticosterone. If you stimulate them with interleukin-6, then definitely you get an increase in corticosterone. So it's very well demonstrated that during pathological stress, other factors that the CRH-ACTH axis are in charge of releasing cortisol. So what happened basically in our body when we are faced with a severe infection, one can see on the CT scan here, one example of one patient who had a CT scan 3 days before having sepsis, and the white arrows are highlighting the adrenal glands. So you can see the volume, the normal volume of these glands. And now, on time of septic shock, one can see that the adrenal glands had increased in volume. This is related to the increased flow to the adrenals with very limited venous blood flow. So you get a rapid enlargement of the adrenals, and one can see that 1 month after recovery from septic shock, the adrenal glands resume their previous anatomical aspects. So, and one can see that this is a very common phenomenon that simply highlights the normal hormonal response to sepsis, which is enlargement of the adrenal glands, production of more corticosterone in animals and cortisone in people to cope with the challenge that results from sepsis. And again, highlighting here the adrenal glands volume, one can see that in that patient there is a major increase in the volume of the adrenal glands during sepsis. Well, what happens during pathological condition? So again, there are numerous works that have been done. One of these work I picked for you is from the group of Irshad Chaudhry. Maybe many of you know Irshad Chaudhry, who was the former editor-in-chief of Shock Journal, and also who was the one who developed the model of CLP, of cecal ligature and puncture induced sepsis. So what he found in his group is, as compared to sham animals in blue, animals with peritonitis have a significant increase in circulating ACTH levels. But if you looked at the plasma levels for corticosterone, one can see that although they are elevated, they are at the same magnitude, the same level than the sham animals. And so Irshad and his team by this time thought that that was an abnormal response. So in spite of having high levels of corticosterone, these levels did not reach the level that was expected owing to ACTH in plasma. So he looked at what happened in the adrenal cortex, and get there to measure the precursor of corticosterone, and indeed found that they were significantly and substantially decreased. So highlighting that in spite of a huge activation of the HPA axis, the actual synthesis of corticosterone was significantly reduced. And that was reproduced by many other people. So Irshad Chaudhry did this on small animals, on rodents. And this is a group of the NIH, of the group of Charles Nathanson, a long time ago, again, where they challenged dogs with intratracheal Staph aureus to replicate the aspects of pneumonia and sepsis-related pneumonia. So you have the baseline cortisol levels and baseline ACTH levels in panel A and B during the animal challenge, showing the kinetics of total and free cortisol and of ACTH. And then it challenged the animals with ACTH, either at low dose or at high dose. And what he found is the grays, what is highlighted in the gray zone, showing that the animals have a decrease in the cortisol reserve. So the ability to increase cortisol by the ACTH stimulation test, whether the low dose or the high dose test, was abnormal, highlighting that after the Staph aureus challenge to the dogs' animals, they developed adrenal insufficiency in a sense where they are no more able to produce levels of cortisol that help counteracting the stress induced by Staph aureus. And this is again a case that happened in a patient. Now you're familiar with this imaging, and look at the adrenal glands of this patient. Unfortunately, that patient was not able to enlarge the adrenals. They remain at the similar volume, indicating adrenal insufficiency. The way the adrenal was responding to the stress here was not appropriate, and that patient died. Of course, it's hard to give causality in between the two phenomena, but at least that highlighted that in patients, in our patients, we may figure out nowadays by imaging whether the adrenal gland response is appropriate or not. Again, looking at the mechanism behind, these are patients who died from abdominal sepsis, and in whom the hypothalamus was assessed and evaluated post-mortem. And in particular, showing here a huge increase of the pro-inflammatory cytokines in TNF-alpha and IL-1 beta in the neurons that are secreting the corticotropin-releasing hormone and the ACTH. And indeed, again, we have tools at the bedside to assess these phenomena by looking at MRI in the patient at the first day of sepsis. One can see that the MRI was normal, but look 2 days after, at day 3, there are increased signals that are located in the Virchow-Robin spaces, highlighting neurogenic edema, highlighting that there is a disruption in the blood-brain barrier that will cause then the dysfunctioning of all the limbic system, including the hypothalamus and the pituitary gland. And the mechanism, one of the mechanisms by which there is this decrease in the synthesis of ACTH, CRH, and by the way of vasopressin in these neurons is very likely related to huge amount of nitric oxide that are released upon astrocytes synthesizing the iNOS And as you know, nitric oxide is a potent apoptotic factor for neurons. So this is one of the mechanisms by which the cytokines triggers iNOS, release nitric oxide kills the neurons, and there is no more capability to synthesize ACTH and thereby to have a normal adrenal response. So in the SCCM, ESICM task force that a few years ago looked at how we can define adrenal insufficiency in the critical ill patient, we had summarized in that paper the main mechanism by which the adrenal gland function might be disrupted during critical illness, and in particular during sepsis. And one can see that all three levels may be affected either by ischemia or necrosis or by inflammatory process. And also there is a possibility of affecting corticosteroid transport to the tissues, or the capability of tissues to capture cortisol to downregulated inflammation at an organ level. So what about the diagnosis of adrenal insufficiency? I think it is likely much easier than one may thought. Yeah, so first of all, you have to keep in mind that in a patient who is critical, if the patient has unexplained fever, unexplained coma, unexplained vasodilatory shock, all these features are likely to be reflecting inappropriate adrenal function. And of course, if in addition to that, the patient has hypoglycemia or hypereosinophilia, you get additional lab information and biomarkers highlighting that the adrenal function is not appropriate. And why is it important? We know it's important because, for example, a normal adrenal function is mandatory for an appropriate response to alpha agonist. If your critical patient has an abnormal adrenal function, he will be or she will be much less sensitive to norepinephrine. So this is very important, and you can even try to disclose or reveal the impaired adrenal function by looking at the capability of the patient to increase blood pressure when you increase norepinephrine titration. Also, these patients will be more likely to have an hyperinflammatory state. So again, if you will look, for example, at circulating cytokine levels, you may find them highly elevated. Or as you know, we have now other ways to subphenotype the hyperinflammatory states in critical patients, and this also may be something that should pinpoint that your patient is at risk of having adrenal insufficiency. And again, it matters because we know that adrenal function is very important to survive stress, is very important to survive critical illness. And if there is too much activation of the HPA axis and a high level of cortisol may reflect peripheral tissue resistance to corticosteroids and impaired, actually, adrenal function. If a response to the synactin test is weak, again, this is highlighting that your patient is at high risk of dying. And if you combine the two information, again, you can have in patient with sepsis a good stratification of whether your patient is at risk of dying or whether he or she will survive. So again, back to the ESICM and SCCM task force, we made several recommendations for your practice. The first recommendation is that we were not able to recommend the delta cortisol over the random cortisol of less than 10. That might be that both of them can indicate adrenal insufficiency in the critically patient. We suggested against the use of free cortisol, and we may discuss this if you wish, or you can refer to the paper where we explain why. We also suggest, again, trying to get free cortisol by measuring salivary cortisol. We suggested that the syndactin test should be dosed with a high dose, the high standard 250 mics, not the low dose, the 1 mic. And also we suggest that it's better to assess the adrenal function using the stimulation test rather than using hemodynamic challenge to see how the patients hemodynamically respond to a bolus of hydrocortisone. And we suggest again the routine measurement of ACTH levels. So I try to summarize for your practice what actually we are doing in my unit. So basically, when we suspect the patient, one of our critical patients who have adrenal insufficiency, we start immediately treatment because the benefit to risk ratio is really in favor of starting immediately treatment. Meanwhile, we will assess the cortisol levels. And if baseline cortisol levels are lower than 5 mics per deciliter, there is no doubt that this critical patient has adrenal insufficiency and you need to continue treatment and also to ask for endocrinologist advices. If the patient has a baseline cortisol levels of more than 18 mics per deciliter, you're almost confident to rule out adrenal insufficiency. You can stop treatment. Many of our patients will be in between. The baseline cortisol levels will be in between 5 to 18. So in that case, the response to the 250 mics of ACTH will be very helpful. If either the peak cortisol is lower than 18 or the delta cortisol is less than 9, then again, the likelihood the patient has AI is really high, and we continue the treatment and ask for endocrinologist advisors. If peak cortisol is above 18 or the delta is above 9, then again, we might be confident to rule out adrenal insufficiency and thereafter to stop the treatment. That's what we are doing in my practice, and so happy to answer any question if you have any question. Thank you so much.
Thank you, Professor Anand, for this insightful talk. We'll save the questions to the end after all the presentations. And so we'd like to welcome Professor Jean-Louis Depaule. He, from France, is extremely prolific researcher and clinician in hemodynamics and fluids, countless number of papers and book chapters that many of you, I'm sure, have read, and currently serves as editor-in-chief of Annals of Intensive Care and editor-in-chief in Journal of Intensive Medicine. Welcome.
Thank you. Good afternoon, everyone. So again, I'm very happy to be here. This is my last talk. I should fly in a couple of hours. So thank you. And I will talk about this title, Inspiratory Efforts and Impact on Pulse Pressure Variation for Fluid Responsiveness Prediction, of course. My conflicts of interest. First, I would like to define very briefly what is fluid responsiveness. It is defined as the capacity of the heart to significantly increase its stroke volume or its cardiac output in response to a volume challenge. And I like to go back to basic physiology. This is a Frank-Starling mechanism with stroke volume on the y-axis and ventricular preload on the x-axis. The relationship is curvilinear, meaning that if you increase preload by fluid, for example, and if the ventricle is working on the steep part of the Frank-Starling curve, stroke volume increases as well. But if you increase preload while the ventricle is operating on the flat part of the Frank-Starling curve, there is no increase in stroke volume, and this condition is called preload unresponsiveness. So fluid infusion will increase left ventricular stroke volume only if both ventricles are preload responsive. So fluid responsiveness is a clinical concept. It is equivalent to biventricular preload responsiveness, which is a physiological concept. Okay, having said that, 25 years ago, it was hypothesized that during mechanical ventilation, the respiratory variation of pulse pressure, which is called pulse pressure variation, PPV, could be a marker of biventricular preload responsiveness and thus could predict fluid responsiveness. PPV, it is the respiratory changes in pulse pressure during mechanical ventilation here, and pulse pressure is the difference between the systolic and the diastolic pressure. When you have a high PPV, this was a hypothesis, when we have a high PPV, probably the ventricle is operating on the steep part of the Frank-Starling curve, and therefore the patient should be fluid responsive. With a low PPV, the patient should be fluid unresponsive. So why we hypothesize this? Why? Because of physiology and because of the heart-lung interactions, briefly. At each mechanical insufflation, we should have a decrease in the right ventricular filling due to the decrease in venous return during the inspiratory phase. And this will decrease the right ventricular stroke volume at inspiration at the same time, but only if the right ventricle is preload responsive. This decrease in the right ventricular stroke volume will decrease the filling of the left ventricle, but not immediately, some seconds later, because of the long pulmonary transit time. And the left ventricle will sense this decrease in filling only at expiration, because it occurs later. And this decrease in filling of the left ventricle should decrease the stroke volume of the left ventricle at the same time, at expiration, but of course only if the left ventricle also is preload responsive. So therefore, mechanical insufflation should change, should decrease the left ventricular stroke volume only if both ventricles are preload responsive. This is physiology. So if I summarize, we like to summarize. We need to summarize. You summarized also, Djilali. Mechanical ventilation induces cyclic changes in stroke volume only if in patients with biventricular preload responsiveness. This is just what I saw. But also, I said before, fluid responsiveness occurs only in patients with biventricular preload responsiveness. This is two separate statements, but we can put this together. If we put this together, we have another statement, which is fluid responsiveness should correlate with the magnitude of the cyclic changes in stroke volume induced by mechanical ventilation. We can substitute stroke volume by pulse pressure, because pulse pressure is proportional to stroke volume, also related to arterial compliance. So if we assume that arterial compliance will not change during mechanical ventilation, during the respiratory cycle, we can assume that pulse pressure variation should reflect stroke volume variation. And this was nicely illustrated by this study by the team of Michael Binsky in animals here. They could measure stroke volume during the mechanical cycle. They could measure pulse pressure during the mechanical cycle. And look, the change in pulse pressure follows the change in stroke volume. So it works. So we can, according to our primary hypothesis, we can state that pulse pressure variation should predict fluid responsiveness. This is the hypothesis behind this concept of using pulse pressure variation to predict fluid responsiveness. Does it work in clinical practice? Yes, it is. This is the first study showing that pulse pressure variation was better than PUP and CVP to predict fluid responsiveness in septic shock patients. This is what we did 25 years ago, probably more. And we also showed that the larger the PPV before giving fluid, the larger the increase in cardiac output after fluid infusion. And the opposite was true. The smaller the PPV before fluid infusion, the smaller the increase in cardiac output after fluid infusion. Many other studies replicated this first study and showed exactly the same results. And of course, we had meta-analysis, like this one published more than 10 years ago from China, showing that it works very well in patients who receive mechanical ventilation with a tidal volume of at least 8 ml per kilogram. Okay, this is perfect, but it's not perfect. It's not perfect because there are many limitations to use PPV at the bedside, at least in ICU patients. Tachyarrhythmia, mechanical ventilation with low tidal volume, which is now currently done in ICU patients, and spontaneous breathing activity, which is the topic of my talk. Again, I don't want to remind this, but if we have patients with mechanical ventilation and persistent spontaneous breathing activity, we know that spontaneous breathing is characterized by irregular respiratory cycles with variable amplitude and then variable effects on intrathoracic pressure, making PPV difficult to predict pleural responsiveness. Also, inspiratory efforts might increase intra-abdominal pressure due to active compression of the abdominal muscles, which might influence both hemodynamics and also PPV as an index of pleural responsiveness in a very complex manner. So it is very difficult to use PPV in patients who receive mechanical ventilation, but with some inspiratory efforts. And this was confirmed in this clinical study we did years ago with Xavier Monet. We only studied patients with mechanical ventilation and persistent spontaneous breathing. As you can see, regarding ROC curves and the prediction of responsiveness using PPV, the area under the ROC curve was around 0.50, so impossible to predict fluid responsiveness using PPV in this case. So how to deal with such situations if we want still to use PPV? Maybe first to consider airway occlusion pressure, PO1. This is a study published last year in Annals of Intensive Care, coming from China, and it was a prospective study including 189 patients, and they separated patients into two subgroups according to the value of P01. When a subgroup with a P01 less than 1.5 centimeters of water, so small inspiratory efforts, small extent, small degree of inspiratory efforts, and patients with P01 more than 1.5 centimeters of water. The prediction of fluid responsiveness was almost excellent in patients with low P01. meaning that maybe we could still rely on PPV in this kind of patients. But the prediction was poor in patients with PO1 more than 1.5 liters of water. So if you have the possibility to measure the PO1, which is possible now on many ventilators, you can look at this. Otherwise, you can use the dynamic changes of pulse pressure variation. Dynamic changes. PPV is already a dynamic parameter, but you look at the change in PPV. The change in PPV in response, for example, to a tidal volume challenge. What is a tidal volume challenge? This was already yesterday described by Sheila Miyatra in this conference. This is a challenge a test consisting of increasing tidal volume transiently over 1 minute only from 6 ml per kilogram to 8 ml per kilogram. And for 6 ml per kilogram, it does not work very well, but when you increase tidal volume to 8, and you look at the difference between PPV8 and PPV6, this works very well to predict fluid responsiveness. This study was performed in mechanically ventilated patients with perfect synchronization to the ventilator with sedation, etc. It is not the case for patients with persistent inspiratory efforts, of course. But this is interesting to know because it is very helpful in the absence of cardiac output monitoring. And now we have a meta-analysis, again coming from China, showing that it works very well in 10 studies and more than 400 patients. Okay. So the question is, can we use this tidal volume challenge in patients who are mechanically ventilated with some inspiratory efforts just by increasing tidal volume by 2 ml per kilogram? This is what we tried to do in this clinical study with Olfa Hamzaoui some years ago. We measured PPV at baseline. It did not work, of course, because of what I said before. But when we performed a tidal volume challenge, we obtained a significantly better area under the ROC curve. And when PPV increases by more than 2%, for example, from 7 to 9%, it can predict for responsiveness. But you look at the area under the ROC curve was not perfect, 0.73. It is far to be 1, so it is moderately acceptable. But it is better than nothing. Maybe another way to do, probably better, is to look at the change in pulse pressure variation in response to a passive leg raising. You know this maneuver, just moving the bed of the patient without changing anything, any angle. The hip angle is the same. And this can transfer blood from the legs and abdominal compartment towards the intrathoracic compartment. So it mimics a free challenge around, depends on the patient, but around 300 ml. And in this study, in controlled mechanically ventilated patients had no inspiratory force, with Temistok Takeri and Xavier Monet, we showed that a decrease in PPV during PLR is reliable to predict for responsiveness. So you perform a passive raising test and you look at the change of pulse pressure variation. If it decreases, probably the patient will respond to fluid administration. This is the confirmation. This study showed this, and this confirms the hypothesis. But again, these patients were fully have a fully controlled mechanical ventilation. And this study was confirmed by others, coming from the group of Jihad Malat, who now works in Abu Dhabi, and they confirmed our initial results. But the question is, does it work in mechanically ventilated patients with spontaneous breathing activity? We tried again to do this in the same study I already showed, and with Olfa Hamzaoui, we showed that a decrease in PPV during PLR predicts responsiveness with moderate accuracy in patients with persistent spontaneous breathing activity, with an area under the ROC curve of 0.78, which is not perfect, but it is far better than 0.50. Does it work in non-intubated patients? This is the next step. Again, we performed a study with Rouichi and Olfa Hamzaoui more recently in totally non-intubated patients, and we looked at PPV and its changes during a passive-like raising test. In fact, it did not work at all. The area under the ROC curve is more or less 0.50. PPV was more or less the same. So it does not predict. But the change in pulse pressure, not PPV, but pulse pressure, the difference between systolic and diastolic pressure, worked. It was an acceptable prediction using the change in pulse pressure. And you know, as I said before, the pulse pressure is a surrogate of stroke volume, and the change in pulse pressure can be considered as a surrogate of the change in stroke volume. And we know that if you measure stroke volume or if you measure cardiac output, you could have a better result with passive-like raising, as it was demonstrated in this meta-analysis we performed years ago with Xavier Monet and Paul Murray. So my conclusions: in mechanically ventilated patients with persistent spontaneous breathing activity, PPV is not a reliable predictor of full responsiveness except if PO1 is low. The changes of pulse pressure variation have a better predictive value than PPV alone, an increase in PPV in response to a tidal volume challenge, or a decrease in PPV in response to passive-like raising, PLR. In non-intubated patients, neither PPV nor their changes during PLR are reliable, but in such patients, the PLR-induced changes in pulse pressure, or better, of course, the changes in cardiac output or its surrogates, are acceptable predictors of full responsiveness. I would like to thank you very much for your attention.
Thank you, Professor Teboul, for sharing those insights. I'm sure we'll have lots of questions. It is now my pleasure to introduce my co-chair, Patrick Biruski, who is a clinical pharmacist in the cardiothoracic critical care domain. He is assistant professor in clinical pharmacology and anesthesiology, has published quite widely in vasodilatory shock and mechanical support of circulatory failure. And this afternoon, he's going to be chatting about vasopressors.
Great, thank you so much for the kind introduction, and again to the chairs and Dr. Abdulrahman for the invitation. It's such an honor to be here with you all, and hopefully we're closing out the conference on a good note. My disclosures are here, not particularly relevant. Unfortunately, all this money goes to my institution and not me. So the Surviving Sepsis Campaign is, of course, a governing body that provides recommendations for all sepsis care, but particularly as it pertains to shock, the provision of vasopressors for the correction of hypotension and shock. And I highlight here that the Surviving Sepsis Campaign recommends the use of norepinephrine as a first-line vasopressor over other vasopressors. And then they go on to suggest adding vasopressin and suggest adding epinephrine when increasing the dose of norepinephrine is insufficient to correct the mean arterial pressure. And we'll highlight here that these last two recommendations are weak recommendations, and the specifics about when and how to use secondary vasopressors in persons who are unresponsive to norepinephrine remain very vague and highly controversial in the literature. And so what do you do about it? This is a survey of over 1,000 clinicians from 80 countries worldwide, and they were asked, when the patient does not respond to your current vasopressor therapy, What is your main reason for adding another vasopressor agent to the current treatment? And you can see here the answers are mixed response, almost even distribution of all the responses. Anywhere from perhaps a predefined maximum dose was achieved, increases in doses were not effective. Perhaps you want to limit or reduce the side effects of the first vasopressor. Maybe you want an independent mechanism or a synergistic mechanism of action with that second vasopressor. And so conceptually, this leaves us in an environment that looks something like this, where you have a population of heterogeneous patients that present with a clinical phenotype of septic shock. We provide a first-line vasopressor. A portion of these patients may respond to this vasopressor, but a portion of them may not respond. And then we add a second vasopressor. Perhaps we introduce other treatments like steroids or nitric oxide modulators. A portion of these patients, again, may respond, but again, some may not. So we go for a third vasopressor, and so on, and we repeat this process. The problem here is that as you increase this time, that you're constantly increasing the vasopressor doses, chasing a satisfactory mean arterial pressure, you're suffering on perfusion targets. And you have subsatisfactory perfusion, you have adverse drug effects because you're increasing very high doses of vasopressors, you're eventually losing responsiveness to vasopressors, and of course everyone knows that the story ends with progressive multiple organ failure and eventually death the further along you get on this continuum. So if we take a step back and we consider blood pressure regulation in normal physiologic health, we'll remind ourselves that there's three major systems that contribute to maintaining blood pressure homeostasis. These include the sympathetic nervous system with catecholamines and the derivatives of catecholamines, the vasopressin pituitary axis, and also the renin-angiotensin system. And when we look back to the textbooks, we'll remind ourselves that if we just want a higher blood pressure, we just give more vasopressors, right? And these are perfect example of data that support this claim. These are data from conscious rats that do not have shock, were administered increasing doses of various vasopressors, regardless of the pressure they received. You can see that the mean arterial pressure continues to increase and increase the more pressure you provide. Again, this is without shock in animals. The same is true in animals who do have shock. Here's a very nice example of a study in dogs. You can see on the left-hand side, without shock, you give increasing doses of norepinephrine, and you have an increased response in the mean arterial pressure. And then you infuse an E. coli to these dogs, and you induce sepsis. You still have an increase in mean arterial pressure with increasing norepinephrine, but that response is maybe a little bit dampened, but it's still there, still incremental increase in mean arterial pressure. The problem is when you translate these concepts into humans, the same is not true. These are data of over 3,000 patients with septic shock from the Open Mimic critical care data set. And you can see here that at low norepinephrine doses, increases in norepinephrine produce a predictable mean arterial pressure response increase. But as you get to higher doses of norepinephrine, the higher you get, the less incremental increase in mean arterial pressure that you receive. And this is very important because excessive catecholamine exposure in persons with shock is detrimental in many ways, and particularly on cardiac performance. Here's a study about 250 patients with septic shock. 1/3 of these patients developed a new arrhythmia after starting norepinephrine for septic shock. And you can see here that the outcomes were worse if an arrhythmia was developed. On multiple regression, the duration and the dose of norepinephrine were predictive of developing an arrhythmia, such that longer durations of exposure to norepinephrine and higher doses of norepinephrine. For every 5 micrograms per minute increase in norepinephrine, the risk of developing an arrhythmia increased by 6%. Additionally, in this very nice study of patients without coronary disease that were receiving norepinephrine, received contrast echocardiography, and you can see that those on higher doses of norepinephrine had lower myocardial blood flow. And this was after correction for the effect of mean arterial pressure. So regardless of what the mean arterial pressure was, the higher the dose of norepinephrine compromised myocardial function. And so outside of catecholamines, we of course have vasopressin that is disturbed in shock. In the early phases of shock, vasopressin concentrations are released from the posterior pituitary, and then after some time are depleted. This is the so-called vasopressin deficiency that we're all aware of. But it's important to remember that not all shock states are the same, and persons with septic shock appear to have inappropriately low vasopressin concentrations compared to other hypotensive syndromes like cardiogenic shock. In the VASH trial, this is a classic vasopressin trial, now almost 15 years ago, that randomized patients with septic shock to receive vasopressin or continued escalation of norepinephrine. And you can see here, when you dichotomize the patients who were randomized when the norepinephrine dose was low and they received vasopressin, their survival was much better than when they received vasopressin when the norepinephrine dose was high. Survival was similar with the placebo group. In an observational study from the Cleveland Clinic, about 1,500 patients with septic shock, they assessed the timing of vasopressin addition to norepinephrine, and you can see here that the odds of hospital mortality continue to increase as you wait to add vasopressin. And they found that for every 10 micrograms per kilogram per minute increase in norepinephrine that you waited to add vasopressin, the odds of hospital mortality increased by 20%. Very recently, a group out of Australia published this excellent paper of about 3,000 patients who received vasopressin in the first 3 days of septic shock. And they separated out patients who received vasopressin within 6 hours of the first vasopressor or after 6 hours. And those who received vasopressin within the first 6 hours were actually sicker. They had higher lactate concentrations, higher Apache scores, and they required more norepinephrine. But despite this, after a severity-adjusted multiple regression, they found that receipt of vasopressin within 6 hours of the first vasopressor was associated with increased survival odds of 30%. And in their linear model, they found that for every 1 hour that you waited from the onset of the first vasopressor to add vasopressin, the odds of hospital mortality increased by 2% for every 1 hour. In addition to vasopressin, there's a disturbance in the renin-angiotensin system during shock. I'll remind you all that the angiotensin converting enzyme is a pulmonary-bound capillary endothelial ectoenzyme. When this enzyme is impaired in situations of endothelial dysfunction, such as shock, trauma, inflammation, sepsis, there's an inability to convert angiotensin 1 to angiotensin 2. And of course, the downstream effects, the blood pressure regulatory effects of angiotensin 2 cannot be activated. And because of this, the juxtaglomerular cells of the kidneys sense low perfusion pressures. They release more renin in an attempt to mitigate this. But the problem is there is no converting enzyme to convert the substrate. And so all of this excess substrate is shunted to an alternative metabolism to the right on this flow chart here, to the production of angiotensin metabolites that are profoundly vasodilatory. These metabolites act on the angiotensin type 2 receptor, the MAS receptor, and produce profound vasodilation. This is the mechanism that you want when you give patients ACE inhibitors with hypertension. It provides vasodilation that treats their hypertension. And of course, ACE is responsible in the degradation of bradykinin. And so when you don't degrade bradykinin, you have more bradykinin available to bind to B2 receptor, to release nitric oxide, to again be vasodilatory. And all of this just cycles on its own. You produce vasodilation, low perfusing pressures, you produce more renin, and again, you just feed this vicious negative cycle of production of vasodilatory substances and high renin. These are very interesting data from the Victus trial. If you all recall the Victus trial, many years ago now was a trial of hydrocortisone, ascorbic acid, and thiamine in septic shock. This is a very large randomized trial. It was, of course, a null trial that was terminated early. The funder withdrew. But what the investigators did is they retrieved frozen specimens from this trial where they sampled blood at the time the patients were randomized. So these data represent a general sepsis and septic shock population that present. And what they found was that as the baseline renin concentration increased in these patients, the hazard of death increased. And when they dichotomized by the study median of 188 picograms per milliliter, the hazard of 30-day death was nearly threefold higher than those with low renin concentrations. So high renin concentrations in pathological shock, regardless of the intervention received, is associated with worse outcome. In the ATHOS-3 trial, the ATHOS-3 trial was, of course, the phase 3 registration trial for angiotensin II that randomized patients with refractory distributive shock to receive angiotensin II or continued escalation of norepinephrine. You can see on the left-hand side, if the baseline renin concentration at the time of randomization was low, the outcome was the same if they received angiotensin II or placebo. Didn't matter. However, if the renin concentration was high, you can see that the persons that were randomized to angiotensin II had nearly twice the survival than those who were randomized to continued escalation of norepinephrine. Additionally, earlier angiotensin II appears to be favorable as well. Our group interrogated the ATHOS-3 trial data, and we looked at patients who were randomized when the vasopressor dose was low. So again, all of these patients required vasopressors, but if they received the study drug when the vasopressor dose was 0.25 micrograms per kilogram per minute or less, you can see here that the survival was nearly twice if they were randomized to angiotensin II than placebo. However, if the vasopressor dose was high, perhaps a signifier of refractory shock, the survival was similar regardless of the intervention. And so we think back to normal physiologic homeostasis and the interplay of multiple regulatory systems that maintain blood pressure and health, and the same can be said for pathologic shock. And so regardless of which vasopressor is given, it appears that giving vasopressors faster to restore perfusion targets is favorable. These are recent data from our group of patients that developed refractory shock. These are all patients, 700 patients with septic shock who required more than 0.5 micrograms per kilogram per minute of norepinephrine. And if they achieved their peak vasopressor dose within the first 6 hours of shock, they were more likely to survive than those who achieved their peak vasopressor dose late. Also, these patients who achieved peak vasopressor dose within 6 hours were more likely to be separated from vasopressors and have more organ support free days than those who achieved peak vasopressor dose late. And vasopressors do appear to play well together. These are very interesting data from the MIMIC data set that looked at patients with septic shock who were receiving norepinephrine that received a second vasopressor. And they did not discriminate the second vasopressor. It was anything. And what they found was that when the dose of norepinephrine was greater than 0.18 micrograms per kilogram per minute, regardless of what the second vasopressor dose was added, the hazard of death tipped over the null. And so when we look back to our concept of how we treat septic shock currently, where we take this stepwise approach, we provide a first-line vasopressor, we wait for that vasopressor to fail, and then we go for a second vasopressor, again, increase the dose of that second vasopressor, wait for that pressor to fail, to then reach for a third one, and so on and so forth. Perhaps instead in the future, we might look to a more personalized approach where we may be more focused on achieving rapid restoration of organ perfusion. Perhaps this includes using vasopressors of multiple mechanisms that are targeted in pathologic shock. Thank you.
Thank you, Patrick, for that comprehensive overview. It's now my pleasure to call upon Kiran Shekhar, who's from Australia. Kiran holds multiple professorships across various institutions in Australia. He's extremely well published in the ECMO domain as well as in sepsis. And this afternoon, he's going to be chatting on innovative mechanisms pertaining to antimicrobial dosing. Looking forward to your presentation.
Thank you. All right. I don't want any of you to miss your flight, so I'll be quick. Also, through this talk, I hope to look into the future. And this talk should hopefully, or hope not, raise your cortisol levels, because AI is going to take all our jobs. So I don't have any conflicts. So sepsis, I know we've spoken about the burden of sepsis endlessly. It remains a global leading cause of death. Still, there are around 10 to 11, 12 million people who die annually with sepsis. It accounts for 20% of global mortality. So despite all the developments in sepsis, effective antimicrobial therapy still remains critical. Of course, not to forget the source control aspects. But it's always challenging in ICU to provide effective antimicrobial therapy. We know many of you pharmacists in the room would appreciate most of these antimicrobials are developed from healthy volunteers. We have a good understanding of altered pharmacokinetics and pharmacodynamics in critically ill, but still there's such heterogeneity between patients. Dosing them remains a challenge. Our patients remain at the risk of therapeutic failure, potential for antimicrobial resistance in the unit and around the world. And of course, sometimes we may end up causing toxicity. Therapeutic drug monitoring, which is not available for most drugs, at least it's available for some drugs, remains the gold standard. And this is pretty much the current situation we are in. But we think if we had therapeutic drug monitoring, even if that means point of care for all the drugs, that may not be the be-all and end-all. It's got significant limitations. Obviously, TDM wouldn't tell you what initial dose of drugs to choose. It's not widely available. For some drugs, it could be expensive to monitor drug levels all the time. And particularly for the beta-lactams and carbapenems, more of the hydrophilic antibiotics, even with TDM, we can run into problems with optimal dosing. And the data on therapeutic drug monitoring is very variable. There are studies for some drugs do demonstrate that TDM works, but there are several other drugs where there is a significant risk of suboptimal plasma concentrations. So we're not dosing our patients as well as we should despite the availability of TDM. So this question's still unanswered to a large extent, especially in critically ill, is how do we choose the right antimicrobial, choose the right dose, and administer it at the right time? And also importantly, when do we start the antimicrobial at the right time? So a lot of these techniques and innovative approaches I'm going to talk about, they're all in the infancy. I know this conference has talked a lot about innovation, and I'm keeping with the theme. clearly by the time we see someone in an emergency department is septic shock. It's too obvious, but it's sometimes late. Whereas how can we then work our way back and try and diagnose infections early? So it's just a matter of time before we'll have the tools. Currently, the clinical picture, obviously, already infections established. Then there are rule-based coding systems, especially within the electronic health records. Even they only detect an infection usually when the infection has already occurred. But there are techniques for nowcasting or forecasting that's being developed that will help us predict infection well before it's clinically manifested. So that's probably what we need to get to is try and predict infections, try and suspect infections in patients. And with all the Internet of Things and wearable watches and a variety of things, the patients can be sitting at home and may get warnings that go and get checked. So these are all very tangible, possible things, and it's just a matter of time before we detect infections well in advance. That will be a big game changer. And what's interesting also, pardon me, is, of course, we talk about precision medicine, and if you look at that beautiful figure there, we talk about all the big, lots of interesting approaches and in therapeutics. But however, we still miss the key thing that we no longer mention antibiotics there, which is a bit of a disappointment. But clearly, we need personalized approaches for antimicrobials as well, because that remains still the mainstay of treatment. So we focus this talk mainly on antimicrobials. What are the key areas for innovation? This is what we call the antimicrobial stewardship cycle, where you have 3 goals. You start the treatment, hopefully at the right time, pick the right drug, and choose the right initial dose, and hopefully you adjust doses as you go in a meaningful way. And you do a set of things during therapy. You reassess if the choice of antibiotic is optimal, if your dosing is optimal, and then you stop the antibiotics at the right time, because you have a moral obligation to do that, because indiscriminate use of antimicrobials has got wider consequences. So we're going to talk about few innovations in antimicrobial dosing, and not everything is available currently. Some are being developed, tested. Clearly AI is the future for many things, and I'm sure it's going to be value add to our practice. So we can use AI tools to machine learn, and point of care therapeutic drug monitoring will be a game changer too if you get it for all drugs. And then there is a science in itself to be developed when it comes to tissue site, target site concentration measurements. These ideas have been there for a while, especially the tissue concentration measurement. We haven't got there reliably yet. And then we need to also look at alternate administration techniques to increase the bioavailability of the drug. So quickly go through the AI and machine learning tools. We'll start with diagnosing infection. That's the most important thing, is to pick up an infection. And you'll be surprised, and there's lots of tools coming using clinically available data or patient sampling or imaging data to increase the accuracy of diagnosis. There were times, I had a colleague who always, senior colleague, she used to say, oh, I can smell Pseudomonas, I can smell Candida. So that kind of AI smells, it's just a way increased sensory perceptions probably in many ways. So AI can help you smell better. So imagine collecting the gas that's exhaled in your ventilatory expiratory limb. And then if that creates a signature. This has been done in space, exoplanets exploration, where you look for bacterial signatures using various techniques. So similarly, the exhaled gases can be analyzed, and you can develop specific signatures that can actually in real time guide you. For example, in this case, if a patient's developing a ventilator-associated pneumonia, if the signatures change, if you're monitoring continuously, you should be able to predict a developing pneumonia in the lungs. So similarly, people have used chest x-rays to, once again, train using AI tools to predict infection, because we can see big pneumonias, but AI may be able to pick up the little changes on X-ray. So these things are coming, and they're not they're within reach. I think these are all tangible and feasible. So let's wait for that. Another biggest dilemma we have is always, especially in ICU, is inflammation and infection. Our patients are so sick, we don't want to take any chance, and the biomarkers we have are hopeless currently. You only believe them if they give you the result you want. I've never seen anyone stop antibiotic in ICU because procalcitonin was low. But if it's high, we all feel good, I made the right choice. So clearly the biomarkers we have are not good enough. But once again, using variety of clinical data, biochemical data, hematological data, there are tools that are being developed that can actually help us discriminate between infection and inflammation in a more sensible way. And once again, each of these techniques, I'm not going to get into the details, I'm just painting the big picture for all of us to think about. Imagine once again, it's going to make our life so much easier if we could reliably discriminate between infection and inflammation. It's got wider global consequences and hopefully stop indiscriminate antimicrobial use. And these have been tested, and there is some early data which is encouraging. And during COVID, it was widely used. I think several AI algorithms were developed, and we learned a lot about this during COVID too. And then once you sort of diagnosed infection, or you separated infection from inflammation, you're now deciding to start antibiotics. Even that AI can assist. Obviously, we need to understand what we're currently doing. If the patient's sick, the sicker the patient, the stronger the antibiotic we choose, and broader the antibiotic we choose. So it's largely empirical. Our loading dose is just, our intuition or whatever. There's our guidelines, which are based often on non-critically ill patients. So we don't know what we are treating. We don't know whether the microorganism is susceptible. So there's a lot of gaps in what we're currently doing, but we are helpless. But eventually we may have rapid diagnostics that will allow us to identify the pathogen within 30 minutes. And they also, some of the other techniques I'll describe will help you choose the loading dose and dose adjust as you go. And hopefully by doing all that, we get to giving the right drug at the right time, in the right dose. These are some of the rapid identification systems. Once again, we are bringing in a variety of things, clinical science, other technologies to identify early bacterial detection, including resistance patterns and susceptibilities can be picked up. And once again, these things have been tested in variety of settings, obviously need to be further tested in clinical trials, but these tests could be run on routine clinical samples and then apply all the deep learning, machine learning techniques, and then overcome all the human limitations in terms of interpreting these test results, and hopefully provide us with a pathogen identification. Similarly, susceptibility prediction. This is one of the papers I really like, where they used 35 data points from existing real world data, and they could model, and from what we see, the area under the curves are quite favorable, and none of them are fancy tests. You don't have to do nuclear scans and all kinds of things that are not available in low and middle income countries. This is going to be a huge game changer, especially in low middle income countries. So knowing the susceptibility, because these are the countries where the resistance is also quite high, and clearly it will be a big improvement. This is one of the techniques we are developing in Brisbane, and not that we developed it, but we are one of those testing it. This is clearly, it wouldn't give you answer within half an hour, but once you set a blood culture and you get the broth, you can run some rapid nanopore sequencing, and we can also use AI integration into that to quickly give an answer, because often we wait 3 days, 4 days or more for blood cultures to come back. But we can overcome that with these sort of rapid sequencing techniques. And once again, when it comes to then antimicrobial dose and dosing intervals, there is, once again, we can build on the existing PK/PD knowledge and more holistically look at the pharmacometrics by adding other covariates listed in the table. For example, this is one of the papers that predicted vancomycin dose in critically ill patients using machine learning techniques. So they input all these covariates along with the TDM data and predict a reliable loading dose and maintenance dose. So, and that's a dosing software essentially. You just put in the data, it will tell you what dose to give to your patient. And once again, this also seems it's not as difficult as going to Mars, so these things will come. This is one of those. Similarly, we tested out the dosing software in a cohort of our patients. We looked at normal dosing and we looked at software guided dosing, and we could achieve, as you see on that graph on the right, we could achieve therapeutic concentrations very easily and very quickly compared to clinician standard dosing. So clearly, dosing softwares at the bedside are going to be imminently coming to your ICU. And what do we do during antibiotics? You've done all this, we started antibiotics, and clearly machine learning can be integrated in the microbiology lab as well. So it can rapidly identify antimicrobial resistant patterns, because we already do flow cytometries, etc. in the lab, but we can accelerate the detection process using various machine learning techniques once again, and the microbiologists will have greater understanding of this. But clearly, whatever we are doing now, AI can help us do it better, quicker, and pick up very minute signs which most of our above our sensory perception essentially. Also, this is one thing that should worry ID physicians, if there's any in the room. But no, I'm not saying that they will be out of business, but clearly, I don't know about you guys, we have an ID round, there's an infectious disease person who comes and reviews every patient. It's great for antibiotic stewardship, but clearly, once again, we can make their life easy. Once again, machine learning models can actually screen the patients in a unit and then identify the patients where you may need extra inputs from them. Otherwise, the system should be good enough to tell you when to stop antibiotics or make changes. Stopping antibiotics, once again, this is a big problem, as we all know. Often antibiotics don't get stopped. Often your inotrope, Presorvine correlates with your, if they're on high dose inotropes, nobody is courageous enough to stop antibiotics, but that can happen in real world. But the machine learning techniques can once you started antibiotics, the clock starts ticking. They keep an eye on a variety of clinical and various other parameters, and they can tell us or guide us when to stop antibiotics. Once again, if you believe in procalcitonin, I don't see any reason why we can't believe in these sort of techniques when they become available. And there is this, once again, compared to, this is called model-informed precision dosing, because precision is what we want in the end. Personalization is what we want in the end. So compared to conventional TDM, a more sophisticated way of approaching dosing is to already you deduct your loading dose based on various PK/PD inputs, if you have MIC data, and then give your initial dose, and then continue to use the data that are available in the real world to build models that will continue to inform your dose changes, also predict any therapeutic failure as you go and make dose adjustments. So once again, we don't have to worry about all this. What is likely to happen is many of these tools can be integrated into our electronic health records, and to a point that you can get a pop-up window that says, by the way, I think your vancomycin level is too low, or dose is too low. So the real-time decision support tools may become available. And so that's more to do with AI and how we use real-world data, because if we look at it, we collect a lot of data, and we don't make use of the data that much. And because, once again, our ability to discriminate the subtle changes in the things we are measuring on a daily basis or a twice daily basis is very limited. If you worked in ICU for 25, 30 years, you develop certain gross pattern recognition skills, but still, no matter how long you work in any specialty, I don't think we'll get those level of precision that comes from AI. So that's something to watch for. And then a couple of last innovations I want to talk about. This particular thing, target site concentration, has always been there. We measure CSF, drug concentrations, and all sorts of body fluids. There are microdialysis techniques where you can actually put in microdialysis probes in target sites. The problem with this is we haven't still found a good correlation between tissue and blood concentrations, because for a drug to get into a tissue, obviously only the free form of the drug gets into the intracellular and extravascular compartments. But once they get there, they also bind to the proteins in those spaces. So what we measure may not be that reliable. So this technique still needs to be refined. There may be other non-invasive techniques that may become available where you can put in a transcutaneous measurement or things like that. They're all within reach. So that's something to watch, but eventually that's probably what we need to get the drugs in the right places. And talking about getting drugs into right places, once again, the field of pharmacology is essentially, it's a field of chemicals, and they haven't looked at more of this drug modifications and disguising drugs in various forms to enhance drug delivery. And once again, these sort of techniques are there. They're being utilized in certain cancer immunosuppressant medications. Once again, well within reach, well within our scope. There are lots of researchers working on it, but we can control where the drug goes, in what quantity, and some of the drugs can reach out like a heat-seeking missile. Your drug can go and seek out the infected areas. So essentially, there are drugs that can actually go and transform at that target site. Once again, these developments will happen to improve our antibiotic dosing. So in summary, I think ineffective antimicrobial therapy is still an ongoing issue. We come a long way with better dosing, better understanding of PK/PD, better administration techniques like a continuous infusion for certain drugs. So we're doing a better job than we used to do, but given the heterogeneity, especially in sepsis and critical illness, is still a barrier. And having a clinical pharmacist in the ICU definitely helps. I don't think AI will get rid of them, but you're also at risk. So we still need to continue to innovate, because in the end, millions of people still die, and that's the bottom line. So ML, and as I said, machine learning can help in a variety of areas, and anything is possible. We need to also look at novel formulations, and we can't just administer chemicals as they are. There are better ways of administering these drugs. But like anything else, everything that glitters is not gold. It has to be tested rigorously in clinical trials, because in the end, it's about trusting these techniques. It's about trusting AI, and trust only comes with time and with evidence. With that, I close, and what a wonderful conference it's been. To the Kuwait team, thank you for having us, and thank you for the great hospitality, and hopefully in a few years' time, we come back with more data to back all these claims. Thank you.
Thank you, Professor Shekhar, for this very insightful talk. We'd like to welcome the speakers up to the stage to answer some questions. We had some technical difficulty at the beginning, but we still have a few minutes for some questions. Oh, I think maybe... Oh, okay. A couple of the speakers have left to catch some flights, but Professor Shekhar and I will be happy to take some questions.
Perhaps I can start by asking you, Patrick, are we moving perhaps towards initiation of dual vasopressors in patients with severe circulatory shock? And your thoughts on the use of methylene blue?
These are two very important questions that are quite hot topic right now. initiation of multiple agent at once is a interesting concept and something that I think deserves some attention. We do this in sepsis, right? Somebody presents with infection. We give them several antibiotics. We collect some data, and then based on the data, we streamline the antibiotic. I think this is a possibility for vasopressors because, again, with sepsis, the goal is to maximize the chance that you target the correct bacteria. And the same can be said for vasopressors. If you have someone who presents with shock, you institute multiple vasopressors with the goal of restoring perfusion as fast as possible. In the meantime, you collect labs, and then you have data to streamline the program. I think it's a real possibility. And the methylene blue is also one that is a quite interesting question too, because although it's not actually a vasopressor, it definitely targets a portion of the pathology that contributes to shock. I think it's challenging because the half-life of nitric oxide is so short, so the window of opportunity of when a methylene blue or other nitric oxide modulator may be beneficial is something that's quite unclear.
Kieran, if I may ask you as well. So one of the things as I grapple with as a clinician is the turnaround times for therapeutic drug monitoring. And ultimately, that's what it boils down to if you're going to effectively dose your patient, because there's so many contributors for either underdosing or overdosing. Where are we in terms of the pipeline for point-of-care therapeutic drug monitoring?
Thank you. No, that's a great question. I think that we're not far. It's just that it needs a lot of validation. The qualitative part of it is the short answer is we're not far. And the nuance to it is that with therapeutic drug monitoring, one thing we could do is like the pregnancy test, for example. You can do qualitative tests where you put a drop of blood and you see the spectrum of colors that emerge, and you can kind of give a rough idea of what it could be. But if you need a proper measurement, it may take much longer. So that qualitative one is definitely in the pipeline, and we're working on it. But it's really hard. It's not as easy as the for example, pregnancy test or troponin is much more challenging. But qualitative testing should be available soon. The quantitative one it comes down to lab. Some labs are good in getting beta-lactam concentration. We get it sometimes in weekdays within 24, 36 hours, whereas on the weekends we don't get it. Yes, I'm hoping that TDM can be replaced by some of the other things we talked about, because it's really tedious. It's not available everywhere. So I think maybe the answer is to move away from TDM, but use it till we develop reliable tools. Yeah.
Yeah, Dr. Patrick, you have given a nice talk about initiation of dual vasopressor therapy. Like in most of the situations, clinical situations I've observed, patient responds to it. Can you just elaborate more about weaning from can you elaborate more about weaning from this dual vasopressor therapy? Do we start in tandem or sequentially? Patient responds to vasopressor therapy. He has been initiated on noradrenaline, then we add vasopressin early. and we see a improvement in his blood pressure. So how do we wean such a patient from vasopressor therapy?
Yeah, this is one question that is kind of being circularly asked in the literature. There's a common saying, and I hear this all the time, last on, first off, which suggests that the last thing you add should be the first thing you remove. But I think this is a flawed approach because you have to go on hemodynamic responsiveness. And I think this is the best way to target how to wean those type of patient is there has to be a evaluation of the hemodynamic responsiveness when these treatments are being used. And that's why I think the question about 2 agents for circulatory failure at one time is a hard one to say yes to right now because we don't have the predictive biomarker that can help guide in the weaning procedure. And so without that, I think it's the hemodynamic response is the best way to separate off, because if you're unresponsive to norepinephrine and you add vasopressin and a few hours later you have stability and then 12 hours later you're ready to wean or something, you know, why would you wean the vasopressin if the norepinephrine didn't work?
Yeah.
Oh, there's one more.
And just to quickly add to that, these are titrable drugs with short half-life, right? So I think for me, you start them, stabilize them, and there is a sense of urgency to wean them as well. These drugs have complications. So you can always try to wean, you can always go back up on the dose as mentioned. But don't give fluid to come off pressors. That is the common problem, so that the patient can go to the ward.
Yeah, we can take one more question. Yeah.
Okay. Hi, Patrick. Thank you for your presentation. My name is Imad. I'm also an assistant professor at Kuwait University. And my specialty is in emergency medicine, so definitely a hot topic that you just talked about in here. My question is still the same concept of vasopressin use. Where I practice in the ICU, remember what we did with vasopressin is just you're in norepi, you reach that cutoff of high dose or kind of getting toward high dose, you start the vasopressin. In my practice, what we did was a vasopressin flat dose. We didn't titrate vasopressin based on the map. So I guess my question is, and you showed us all the data supporting vasopressin, was it a fixed dose vasopressin or was it a titratable?
Yeah, that's a great question. The majority of the data or the observational data I presented was mainly fixed dose, and that's how it's been adopted. But it's a very interesting question that doesn't have a compelling answer to it, because if you look back at major trials randomize patients to a titratable vasopressin. The VASH trial, the VANISH trial, the VANCH trial in cardiac surgery are 3 examples of major seminal trials where the randomization schema mandated the titration of vasopressin in those arms because presumably because they needed to maintain blinding with norepinephrine. The premise in my belief is that the application of fixed dose is on the belief that vasopressin deficiency is a hormonal situation in shock, and I think that's only part of the story, because there are vasopressin receptors throughout the systemic vascular bed that are G-coupled protein receptors, just like adrenergic receptors, and so there is a direct vasoconstrictive effect from vasopressin outside of its hormonal situation with the pituitary axis.
All right, thank you.
Well, thank you to all the attendees for attending this session, and we hope you had a wonderful conference.
Thank you very much.